Welcome everyone to today's presentation on common ENT problems in primary care. We are FMS from PKD Sabak Bernam, Selangor. Our goal is to provide an in-depth understanding on common ENT conditions, their causes, symptoms, and effective treatment strategies. This session is designed to benefit healthcare professionals and anyone keen on improving patient outcomes in ENT care. Our presentation is divided into three parts. Part 1 is the common ear problem, Part 2 is the common nose problem, and Part 3 is the common throat problem. Now let's begin with Part 1, the common ear problems in primary care. Let's begin with the outline of this presentation. For each section, we will discuss clinical features, diagnostic methods, and evidence-based management practices. By the end of the session, you will have a clearer understanding on ENT workflows and treatment protocols. In this section, we will examine the anatomy of the ear. The ear is composed of three primary sections, the outer, middle, and inner ear. A thorough understanding of these anatomical structures is essential for accurately diagnosing and managing various ear conditions. For the diseases of the outer ear, we will focus specifically on conditions affecting the external auditory meatus and the pinna. Otitis externa is a common condition characterized by inflammation of the ear canal. It can be acute or chronic and is usually caused by bacterial infections. It can also be caused by non-infectious causes such as skin disorders and allergy reaction. For clinical features, it can be divided into mild to moderate stage as well as severe stage. For mild to moderate stage, patients may present with pain and increased pruritus. Examination include erythema, progressive edema, debris within the ear canal, and discharges are commonly observed. Meanwhile, in the severe stage, patients experience intense pain, particularly exacerbated by ear movement. Examination's findings may include complete obliteration of ear canal lumen, purulent otorrhea, and potential involvement of the preauricular soft tissues. 4 principles of treatment, which include number 1, ofloxacin ear drop, number 2, frequent ear toilet, number 3, pain control, and finally number 4, implementation of preventive strategies to reduce the risk of recurrence, including proper ear hygiene and avoiding exposures to moisture. Chronic otitis externa is marked by persistent symptoms of more than 3 months, such as itching and mild discomfort. It may result from bacterial, fungal infections or dermatological conditions. Signs of chronic otitis externa include dry, flaky skin, hypertrophic tissue, and mucopurulent otorrhea. Risk factors for this condition encompass water exposure, trauma from ear, digging, and immunocompromised state such as diabetes. This condition warrants a referral to an ENT specialist. Furunculosis is a localized infection like folliculitis occurred in the external auditory canal, specifically at the lateral 1/3 of posterior superior canal. It is commonly caused by Staph aureus. These infections present with pain, redness, and swelling. Mild cases are treated with warm compression and oral antibiotics. Meanwhile, abscesses may require incision and drainage. If there is any soft tissue extension involvement, referral for parenteral antibiotic is indicated. Next, I'll be discussing on otomycosis, a fungal infection of the external auditory canal. It can be either primary or secondary. The most frequent organisms are Aspergillus and Candida. The risk factors include number 1, water exposure, number 2, trauma from ear digging, number 3, skin problems which can increase susceptibility, and finally number 4, immunocompromised state like type 2 diabetes mellitus. Otomycosis symptoms are often difficult to differentiate from bacterial otitis externa. The patient may experience deep pruritus or itching within the ear, along with dull, discomforted pain. Obstructive hearing ear loss is common, and tinnitus or ringing of the ear may also present. On examination, signs of otomycosis typically include erythema or redness of the ear canal, along with edema or swelling. Additionally, there is often the presence of fungal debris, which may appear white, grey, or black within the canal. Management of otomycosis involves thorough oral toileting and ensuring proper drying of the ear canal to remove any excess moisture. Topical antifungal treatment such as clotrimazole ear drops is commonly used to address the fungal infection. Malignant otitis externa is a severe, often life-threatening infection typically seen in diabetic and immunocompromised patients. The infection is most commonly caused by Pseudomonas aeruginosa. Patients with poorly controlled diabetes or a history of otitis externa at an increased risk for developing this condition. The symptoms include deep-seated severe oral pain, chronic otorrhea, and a sensation of fullness in the ear. One of the key indicators is that the symptoms do not improve with typical antibiotic treatment, which raises suspicion for a more serious infection. On examination, we may observe significant inflammation and granulation tissue in the ear canal. Purulent secretions are common, and the ear canal may be completely occluded, with the tympanic membrane also being obstructed. In more severe cases, there may also be involvement of cranial nerve. The diagnosis of malignant otitis externa relies heavily on clinical findings, particularly in immunocompromised patients presenting with external otitis. High suspicion should be maintained in these cases. Additional diagnosis steps include laboratory investigations to confirm the causative organism and imaging studies to assess the extent of the infection and involvement of surrounding structures. For management, immediate ENT referral is critical, with treatments involving systemic antibiotics, local debridement, and addressing underlying immune suppression. We shall now proceed to discuss the diseases of pinna. Now, let's discuss the preauricular sinus, a small pit near the external ear canal. It's a congenital malformation resulting from first brachial cleft anomalies during fetal development. Typically, preauricular sinuses are asymptomatic and require no treatment. However, if infection occurs, systemic antibiotics such as cefalexin or cloxacillin are prescribed. If an abscess forms, incision and drainage is necessary. For recurrent infections or persistent issues, surgical ligation may be required to close the sinus and prevent further complication. Perichondritis is an infection of perichondral layer surrounding the ear cartilage. It can result from trauma to the auricle or occur spontaneously, especially in diabetes patients. Symptoms include pain over the auricle and deep in the canal, along with pruritus. Symptoms to look for include a tender auricle, induration, and edema. In advanced cases, there may be weeping, crusting, and involvement of the surrounding soft tissue. Treatment depends on severity. Mild cases are managed with topical and oral antibiotics, while more advanced cases require hospitalization and IV antibiotics. Pinna hematoma occurs due to blunt trauma, causing blood to accumulate between the cartilage and the skin of the ear. It presents as firm, painful swelling that develops rapidly. Immediate evacuation of the hematoma using the button stitch technique along with systemic antibiotics is essential to prevent infection. If left untreated, it can lead to cauliflower ear due to disrupted blood supply to the cartilage. Prompt treatment is crucial to avoid permanent deformity. The next topic is the diseases of the middle ear. Tympanic membrane, also known as the eardrum, is a thin cone-shaped membrane that separates the outer ear from the middle ear. During otoscopic examination, we need to look at the character of the tympanic membrane. First, the color. Pearly grey is indicative of a normal tympanic membrane, while redness is suggestive of infection. Second, the transparency to assess for fluid and opacity. Third is the position to assess if it's bulging or retracted. And finally, number 4, the landmark, to identify other structures, for example, like the cone of flight or the malleolus handle. Otitis media is an inflammation of the middle ear which consists of eustachian tube, tympanic cavity and mastoid bone. Acute OM lasts less than 3 months, while chronic OM persists more than 3 months. WHO defines chronic OM as more than 2 weeks of otorrhea. Risk of acute OM is 200 times higher in the first 2 years of life as compared to in adults. There are 4 stages of acute otitis media, each with distinct features. In the stages of tubal occlusion, pre-suppuration and suppuration, patients may experience fever, otalgia and hearing loss. In the resolution or complication stage, the tympanic membrane may either heal or rupture, leading to a mucopurulent or bloody otorrhea. Middle ear effusion can persist for 1 month in 30% of cases, whereas for 2 months in 20% of cases. In severe cases, patients may develop complications of OM, especially those with symptoms like headache, pyrexia, otalgia, ear discharge, and altered mental status. These complications may involve either intratemporal and intracranial, such as meningitis, sigmoid sinus thrombosis, or brain abscess. For the management part, management includes pain relief, watchful waiting for mild cases, antihistamine, decongestion, and antibiotics. For a recurrent and severe infections, surgery by ENT is indicated. The decision to prescribe antibiotics for acute otitis media should be based on the National Antibiotic Guidelines 2024. Most uncomplicated otitis media do not require antibiotics, with exceptions for children under 2 years old, immunosuppressed individuals, or severe cases. Watchful waiting for 48 to 72 hours is recommended if symptoms can be managed with analgesia. A few antibiotics can be prescribed for both adults and pediatric patients, including amoxicillin, augmentin, or erythromycin. Cholesteatoma, a malignant complication of chronic otitis media, can lead to fatal complications such as lateral sinus thrombosis, brain abscess, meningitis, CSF leak, facial paralysis, and hearing loss if untreated. This condition requires an urgent referral to ENT specialists. Let us now shift our focus to hearing loss. There are 3 types of hearing loss. The first one, conductive hearing loss. It involves a blockage or damage in the outer or middle ear. This can result from ear infection, fluid in the middle ear, earwax buildup, or damage to the eardrum or ossicles. Second is sensorineural hearing loss. It results from damage to the inner ear or the auditory nerve. It can be caused by aging, noise exposure, genetic factors, or infection. And lastly is the mixed hearing loss. It is a combination of both conductive and also sensorineural hearing loss. Next, we look at the screening and diagnosis for hearing loss. Early detection starts with public awareness on hearing loss symptoms such as difficulty hearing conversation or frequent volume adjustment among affected family members. Then, basic tests needed to be carried out at the primary care level like the whisper test, Rini and Weber test, and otoscopy. And lastly, when screenings indicate issues, comprehensive evaluation by audiologists follow. These include detailed audiological testing, speech recognition tests, and imaging if necessary to identify the types and severity of hearing loss. What are the impacts of hearing loss? Hearing loss impacts social engagement by making conversations difficult, straining relationships, and leading to isolation. It decreases overall quality of life and satisfaction, increases the risk of dementia, and is linked to a higher likelihood of falls. Early treatment can reduce these effects. What are the treatment options of hearing loss? Hearing aids amplify sounds and are suitable for individuals with mild to severe hearing loss. Assistive devices enhance the volume of phones, televisions, and other sound sources, improving accessibility. Cochlear implants are designed for those with severe to profound sensorineural hearing loss, providing direct stimulation to the auditory nerve. And lastly, surgical procedure is for those who are indicated. That's the end of the common ear problems in primary care. We shall continue with the part 2, the common nose problem in primary care.